Step 2 CK Final Grand Sprint. Let's begin. A patient on a mechanical ventilator suddenly develops hypotension, tachycardia, and unilateral absence of breath sounds on the left. What's the best next step in management? Urgent needle decompression. The key clue here is hemodynamic instability. A really tempting trap is ordering a chest X-ray, but that only becomes the right answer if the patient is actually hemodynamically stable.
A patient presents with a rapid onset of hives, vomiting, diarrhea, and hypotension right after a meal. What's the best next step in management? Intramuscular epinephrine. Your key clue is those gastrointestinal symptoms combined with hypotension. A tempting trap is IV antihistamines. That only becomes correct if they're having a mild allergic reaction limited just to the skin. A patient rescued from an enclosed space fire has singed facial hair, wheezing, and oropharyngeal blistering. What's the best next step in management? Endotracheal intubation. The blistering is your massive key clue for impending airway compromise. You might be tempted by bedside fiber optic laryngoscopy. That's your answer only if the patient is stable with concerning features but lacks strong indicators like blistering. A patient presents with massive hemoptysis from the right lung. What's the best next step in management? Placement in the right lateral decubitus position. The key clue is the massive bleeding. A trap here is supine positioning. That becomes the correct answer if the hemoptysis is small and totally non-life-threatening.
A pregnant patient at 32 weeks involved in a motor vehicle accident presents with sudden vaginal bleeding, a rigid tender uterus, and hypotension. What's the best next step in management? IV fluid resuscitation and left lateral decubitus positioning. Your key clue is the unstable vitals and rigid uterus screaming abruptio placenta. Immediate cesarean delivery is a huge trap here. That only becomes the answer if the patient is hemodynamically stable but has a non-reassuring fetal heart tracing. A pregnant patient at 34 weeks presents with painless third trimester bleeding and totally normal vitals. What's the best next step in management? Transabdominal followed by transvaginal ultrasound. The key clue is the painless bleeding pointing to placenta previa. A digital cervical exam is a trap. That's only correct if an ultrasound has already definitively ruled out placenta previa and the patient is in active labor.
A pregnant patient at 36 weeks presents for evaluation of painless third trimester bleeding. What's the best next step in management? Ultrasound before any digital exam. The key clue is third trimester bleeding with an unknown placenta location. Again, a digital vaginal exam is a trap. It only becomes the answer if placenta previa has been definitively ruled out. A reproductive age female presents with acute pelvic pain, normal vitals, and a soft abdomen without peritonitis. What's the best next step in management? Pelvic exam and a pregnancy test. Stable vitals and a soft abdomen are your key clues. Diagnostic laparoscopy is the trap here. That only becomes correct if the patient is hemodynamically unstable with peritoneal signs. A 15-year-old female presents with primary amenorrhea, normal secondary sex characteristics, and an absent uterus on ultrasound. What's the best next step in management? Karyotype. The absent uterus is the absolute key clue. Checking an FSH level is a trap. That's the correct answer only if the uterus is actually present on the ultrasound. A pregnant patient presents for her routine first prenatal visit at 8 weeks gestation. What's the best next step in screening? Screen for rubella and syphilis. The key clue is that this is the routine first visit. A GBS rectovaginal culture is the trap. That's your answer only when she hits 36 to 38 weeks gestation. A patient in active labor at 38 weeks had a positive GBS culture. She reports a mild penicillin allergy consisting only of a rash. What's the best next step in management? Administer a cephalosporin like cefazolin during labor. The key clue is the word mild for her penicillin allergy. Clindamycin or vancomycin is a trap. Those become the right answers only if she has a severe anaphylactic allergy to penicillin.
A patient with inflammatory bowel disease presents with fever, tachycardia, hypotension, and an abdominal X-ray showing colonic dilation greater than 6 centimeters. What's the best next step in management? Bowel rest, nasogastric decompression, antibiotics, and IV corticosteroids. The key clue is IBD-associated toxic megacolon. Antimotility agents are a trap. They only become correct for uncomplicated, non-infectious diarrhea without megacolon. A patient with severe abdominal pain and distension after a diarrheal illness needs evaluation for toxic megacolon. What's the best next step in management? Abdominal X-ray. The key clue is the need to safely identify colonic dilation greater than 6 centimeters. Colonoscopy is a dangerous trap here. It's only the answer if the patient requires routine inflammatory bowel disease surveillance and is entirely stable. A patient being treated medically for toxic megacolon suddenly deteriorates clinically and develops peritonitis. What's the best next step in management? Emergency surgery. The clinical deterioration indicating possible perforation is your key clue. Switching antibiotics is the trap. That only becomes the answer if they're hemodynamically stable but just failing to improve after a few days without peritonitis.
An older patient suffers a traumatic hyperextension injury of the cervical spine and presents with weakness that is significantly worse in the upper extremities than the lower extremities. What's the most likely diagnosis? Central cord syndrome. The key clue is the hyperextension mechanism combined with that disproportionate upper extremity weakness. Anterior cord syndrome is your trap. That becomes the answer if the patient has bilateral loss of pain and temperature sensation, but perfectly preserved proprioception. A patient presents with acute right-sided weakness that started 2 hours ago, and a head CT shows absolutely no hemorrhage. What's the best next step in management? IV thrombolytics. The key clue is the time window under 4.5 hours with zero hemorrhage. Aspirin alone is the trap. That becomes the answer if the symptom onset was more than 4.5 hours ago. An attending physician actively treating patients on a shift smells of alcohol and is slurring their words. What's the best next step in management? Immediate removal from clinical duties. The key clue is the active threat to patient safety. Privately counseling them to finish the shift and then report is a massive trap. That's never the correct answer. You literally must intervene right away when patient safety is at risk. A 45-year-old patient presents with new bifrontal headaches occurring right upon awakening, accompanied by nausea and blurry vision for the past month. What's the best next step in management? Brain MRI. The key clue is a new headache in a patient over 40 that hits when they wake up. Reassurance and NSAIDs is the trap. That's only right if they have long-standing classic tension headaches at the end of the day. A patient presents with severe low back pain, symmetric perianal numbness, hyperreflexia, and bowel dysfunction. What's the most likely diagnosis? Conus medullaris syndrome. The key clue is those upper motor neuron signs like hyperreflexia and symmetric deficits. Cauda equina syndrome is the trap. That becomes the answer if the patient presents with severe radicular pain, hyporeflexia, and asymmetric saddle numbness. A patient presents with severe radicular low back pain, asymmetric saddle numbness, hyporeflexia, and urinary retention. What's the most likely diagnosis? Cauda equina syndrome. The key clue is the strictly lower motor neuron presentation with asymmetric deficits. Cauda medullaris syndrome is the trap here. That becomes correct only if the patient presents with hyperreflexia and symmetric perianal numbness.
A patient presents with a finger stuck in flexion, fusiform swelling, and severe pain with passive extension. What's the most likely diagnosis? Flexor tenosynovitis. The key clue is the presence of the classic Canaveral signs. Rheumatoid arthritis is the trap. It only becomes the right answer if the patient has chronic symmetric morning stiffness that actually improves with use. A patient suffers a severe traumatic spinal cord injury resulting in paraplegia. What's the best acute management step for their genitourinary system? Urinary catheter placement. The key clue is preventing acute bladder distension and damage from retention. Urodynamic testing is a trap. That only becomes correct if the patient is undergoing a chronic spinal cord injury evaluation. A patient with anaphylaxis received IM epinephrine with initial improvement but required 3 subsequent doses over the next hour. What's the best next step in management? Hospital admission. The key clue is multiple epinephrine doses indicating a super high risk for biphasic anaphylaxis. Discharging them home with an epinephrine autoinjector is a trap. That's only correct if they require just a single dose and remain completely symptom-free after observation.
A patient holds both arms outstretched with palms facing upward, and one arm slowly drifts downward and pronates. What's the localized neurologic pathway dysfunction? Pyramidal tract or upper motor neuron disease. The pronator drift is your undeniable key clue. Posterior column disease is the trap. That becomes the right answer if the patient has an upward drift with searching fingers due to a loss of proprioception.
A patient rescued from freezing temperatures has superficial pallor and anesthesia of the fingers. What's the best next step in management? Rapid rewarming in a warm water bath. The key clue is frostbite without systemic compromise. Attempting rapid rewarming in the field prior to transport is a trap. That's only correct if there is absolutely zero possibility of the tissue refreezing before definitive care can be provided. A patient with frostbitten toes is found to have a core body temperature of 34 degrees Celsius. What's the best next step in management? Treat the systemic hypothermia first. The key clue is the core temperature sitting below 35 degrees. Immediate local rapid rewarming of the toes is the trap. That's only correct if the patient's core temperature is strictly normal. A patient has severe, limb-threatening frostbite that is failing to improve after rewarming. What's the best next step in management? Thrombolysis or angiography. The key clue is failing to rewarm, pointing straight to severe thrombosis. Early surgical amputation is the trap. That only becomes the answer if weeks to months have passed and the tissue is fully demarcated.
A patient experiences brief episodes of vertigo triggered by head movement, and the Dix-Hallpike maneuver causes nystagmus. What's the most likely diagnosis? Benign paroxysmal positional vertigo. The key clue is the brief positional trigger and a positive Dix-Hallpike. Meniere's disease is the trap. That becomes correct if the vertigo lasts for hours and is accompanied by hearing loss and tinnitus. A patient presents with an acute, single, prolonged episode of vertigo lasting for days following a viral illness. What's the best next step in management? Vestibular suppressants like miclizine. The key clue is a single, prolonged episode post-viral illness pointing to vestibular neuritis. Antibiotics are the trap. That's your answer only if the patient has bacterial labyrinthitis with purulent ear discharge and high fever. A 15-year-old female presents with a lack of menses but normal development of secondary sex characteristics. What's the best next step in management? Reassurance. The key clue is hitting that age 15 threshold with normal secondary characteristics. A pelvic ultrasound is the trap here. That only becomes correct if she reaches age 15 with no menses and also lacked secondary sex characteristics by age 13.
Unstable first. Always assess ABCs before specialized tests. Check glucose or calcium first for altered mental status or ECG danger. Always verify pregnancy status and reproductive age females. Respect strict age thresholds for screening and diagnoses. Identify the high-risk host, whether they're immunocompromised or elderly. Prioritize source control in sepsis. Only order imaging if it directly changes your management. Memorize absolute contraindications for vaccines and medications. Know the difference between capacity and competency. And ensure safe disposition before discharge.